Good afternoon and welcome to Preventing Physician Burnout, COVID-19 Special Edition, a Health System CIO Media Inc. production sponsored by PerfectServe. Just a little housekeeping before we get started. My name's Anthony Guerra. I'm the Editor-in-Chief at Health System CIO, and I'll be your moderator today. We've got some interactive features we want you to take advantage of. Questions and comments, of course, you can send them in the Q&A box as they occur to you, and we'll take them a little later in the program. And we're going to have a nice audience poll that we put out later. Hopefully you can participate in that, and we will discuss the results. Just so you see how we're going to spend our time today, first we're going to go 35, 40 minutes or so with our main panel discussion featuring Stephanie McIntyre, VP and Chief Applications Officer with SCL Health, Dr. Brett Oliver, CMIO with Baptist Health System, Kentucky and Indiana, and Ben Moore, Chief Product Officer with PerfectServe. And then we'll have our audience Q&A. So let's jump right in. Stephanie, let's start with you. Can you give us an overview of your organization and your role?
Absolutely. So I'm the Vice President of Applications at SCL Health, and in that role, I have the pleasure of working across really all of our ministry, clinical, revenue cycle, and also business operations. So have responsibility for all the applications. As far as SCL Health, for those that are not familiar, we're a not-for-profit Catholic healthcare system and primarily cover Colorado, Montana, and some parts of Kansas. We have some safety net clinics there. 8 acute facilities, over 200 practices. We also offer home health, hospice, as well as behavioral health.
All right, Stephanie, thank you very much. Brett?
Hi, yeah, thanks, Anthony. I'm a family physician by background, still see patients 1 day a week, although during COVID I have had a 6-week hiatus of focusing on all things IT. Baptist Health is a 8, soon to be 9 hospital non-for-profit system, and primarily in Kentucky, but we have a 1 hospital in southern Indiana, 300 points of care, have a medical group of about 1,400 plus folks, and like Stephanie, we've got home health and some behavioral health, and pretty much a full-service health system.
Very good, Ben.
Yes, thank you very much, and good morning, everyone. I'm Ben. I'm the Chief Product Officer of PerfectServe. We're a unified healthcare communications company. We've been in business for about 20 years. We can be found on roughly 1 in 5 physicians in the US using our product, over 500,000 users in our platform, including nurses and other care team members, roughly 400 hospital locations and 27,000 clinics. And what we do is improve communication between clinicians as well as patients and their family members with the ultimate goal of improving patient outcomes. We also focus on provider scheduling to build optimized schedules that help reduce physician burnout. As far as my background, 10 years ago, I got into the industry as the CEO and founder of a company called Telmedic that was acquired in 2018. I got into the business because of a breakdown in communication in the healthcare system that put my family's safety at risk.
Real quick, Ben, moving from unified communications to scheduling, did you see that as a natural, what's the connection there? And did you see that as sort of as a natural evolution, what you were doing?
Yeah, we did, because a lot of communications proper communications in healthcare are driven by the provider availability and call schedules. Mm-hmm. So by putting the two together, you're able to optimize communications and, for example, not interrupting the wrong provider at the wrong time.
Oh. Right. Yep, that makes sense. Very good. All right, let's get into it. Brett, let's start with you. Describe the impact COVID has had on your organization.
Oh gosh, I mean, it's pretty much disrupted us from top to bottom. A lot of negative ways in terms of patient access and things. It's been hard on providers in terms of the burnout piece when you're taking away the element of touch in a lot of ways with PPE and masking and not seeing folks, doing it by video. There's also been lots of very heavy discussions for physicians and nurses and the like. For instance, we've been talking over the last 3 to 4 weeks amongst the chief medical officers at each of our hospitals about ventilator allocation policy. Fortunately, it looks like in Kentucky and Indiana, we're going to be spared some of that decision making, but we've had to have the conversations about what do you do when you run out of a certain resource like a ventilator. Having conversations with our EHR vendor as well as our providers about what do you do if you have to split a vent for 2 patients? What are going to be the priorities there? Those are conversations that we're not used to having in mass like that. I mean, you have those individual patient ethical questions, but boy, that's just added to the impact on the organization. We've had financial impact. We've had a furlough across the organization for 6, 8, 10 weeks is what it's expected to be. It's affected, just the ability to take care of patients overall. On the positive side, though, we were talking a little bit before we got started, Stephanie, there's really been a somewhat unexpected rallying around this common enemy. It has really been fabulous and very joyful, and not to take away from the seriousness of the COVID crisis, but it's been joyful to see everyone rallying around that and giving each other a lot of grace as things don't roll out just perfectly because you've got such a compressed timeline.
Brett, it's fascinating because, and we're going to talk about this throughout the webinar, but there is this dichotomy of an increase of stress and an increase of burnout perhaps, and these tough decisions that, to me, you think of only having to be made en masse in almost a combat situation, combat medics making these decisions, right? I remember the show MASH, right? I don't know if anybody remembers that show, but that was a lot of all the patients came in and you triage, right, en masse. So you've got that, but you've also got what you mentioned with this sort of this focus and sense of mission and meaning and coming together and heroes. We are heroes and just the acknowledgement. So that uplifts. So is it really that two-sided coin?
I think it is to an extent. I think if this were to persist for months and months and months, it would be tough to maintain that focus. And it's been isolated. The major stressors are around emergency department caregivers, the intensivists, the hospitalists. So you've got primary care rallying around those colleagues saying, hey, listen, I used to work in a hospital, or you give me a little training, I'll do it, or I'll work in one of the urgent cares. Right, in the relative short term, it's a very big positive. And I think on the other side of this will be very helpful for our organization moving forward. The relationships forged through some of this, that won't change. I do worry if we were to hit a surge, is this different for us in Kentucky and Indiana than it is in New York? I have to believe that it is.
Very good. Stephanie, your thoughts on how this has impacted your organization?
I have to echo a lot of Brett's comments. It has been disruptive. It's been disruptive financially. It's been disruptive programmatically. And I think anytime you have a situation where, you have a novel virus, you have something unknown, the impact, the numbers of patients are unpredictable. You're in a resource, crunch situation and having to have those tough conversations around, how do we make decisions, at scale, if we need to plan for vent use. It's a scary experience and not one that, at least I've had in my career. So that's stressful, but, we've also seen, a lot of those positive impacts when we've been pushed to get out of our traditional lanes and kind of shake up our traditional ways of working, we get in ruts. It's certainly pushed us together, and I think in a lot of cases allowed us to think differently, to be, innovative in places where we need to be, and also, move to solutions quickly. When we talk about, provider burnout in the process, it's not always about the change. Sometimes it's about all the belaboring that, we do ahead of time, and we haven't had that luxury. So it's been really exciting and gratifying to see, when we work together as a team, we figure out what needs to be done. We're able to move to those changes swiftly and see the positive impact we really are a lot more resilient and nimble than I think, sometimes we give ourselves credit for. And I'm hopeful that as we go back into those lanes and pick up our, regular programming, that we're able to remember those moments and have some confidence in what the team can produce together.
Very good. Ben, your organization, both as a service provider, you got a lot of customers. So
right.
You got a lot of customers that have a lot of needs. And your communications tools would be something that could help them get through a time like this. So what are you seeing on your end, both from your customers and in terms of, have you been seeing a big uptick in requests for your services, that type of thing?
Yeah, thank you for asking. I just want to first give a shout out that, we're in complete awe of what our customers do every day at PerfectServe. And in this exceptional time, even now more than ever, and I just want to thank our frontline medical teams and staff and the IT teams that support them in this very challenging time. And Stephanie and Brett, I just want to give that shout out. It's been profound for us at PerfectServe. We've been working tirelessly around the clock. Platform usage has gone up over 400%. We've been deploying COVID-19 specific tweaks and use cases to over 150 locations. And it's different for us because we're doing this all working from home, where we're used to actually being in those hospitals with our partners as a high-touch company. So that's been a new paradigm for how we deliver our solutions. And there are some changes that I think I'm going to get to describe a bit later on in the products. One example is the use of video. It's exploded for us as well. And one example is helping reduce the risk of infection to frontline medical staff by using virtual visits. And the other is new telehealth workflows that haven't been deployed before in the industry. On a scheduling front, we're seeing this a huge surge in demand, coupled with the issues in supply that Brett alluded to with providers, and so being able to adapt resources really quickly on the fly and allow our customers to get providers scheduled without having them burnt out. I think a lot of this change that we're seeing is permanent, and we're not going to go back to the way we did. It's not going to be business as usual post-pandemic.
I think that's an interesting point, and let's go with that a little bit further. Stephanie, your thoughts on the permanence of some of the things that are happening, both culturally and then technically in terms of people working remotely, remote visits, that kind of thing. There's a suspicion that the relaxations that have been put on telehealth will not go back to the way they were. Mm-hmm. So your thoughts around that?
I have to agree with Ben. I think it is going to be different moving forward. One of the upsides of the pandemic, is that it's really created an organic situation where we force people out of their comfort zones because there's been, no other alternative. So for someone who may have said, I'm not interested in a virtual visit, I'm uncertain about that, I don't know what it means, or even providers, who may be reticent, and again, I can't stress enough the importance of having that relationship, and some of that needs to be face-to-face, but there are use cases where it does make sense to use some other, means of care. Pushing people out of that comfort zone in this situation gives, I think, individuals an opportunity to test their assumptions or test, question maybe a bias that they may have had going in. So experience is very important, and I think in a lot of cases, those experiences have been really positive, and would hope to see that, we would continue to think that way. And also hope to see that, the various regulatory bodies and our payers, see the value in that as well and are as progressive as we would like to be, going down that path.
Brett, thoughts on some things that will not go back to business as usual? And we don't even know if and when business as usual goes back, if it ever does. And we don't know about resurgent, people talking about the fall. You mentioned fatigue. It's one thing to get through it the first time. It comes around again. People a little exhaustion. I can't do this again. But your thoughts?
Right. No, that's fair. I see it on two different levels. On a clinical level, yeah, I don't know. We go back from a video visit perspective. What I've seen, the hurdles amongst my colleagues that would say, no, my patients don't want this. That's crappy medicine. All this, they're gone. Like as soon as they couldn't see patients in person, they're gone. And so it's fantastic to see those same people come back with new ideas. Hey, could I do this with a post-op video visit check? I really don't need to see them unless they're having this, or this. Could I do that? And getting them coming forward rather than pushing it to them, that's been exciting to see. And I think we'll just continue to see use cases and ways that we can use technology to improve efficiencies, which from a burnout perspective, hopefully that gives time back to a provider. And whether they want to see more patients with that time or they want to go home is on them. From an organizational standpoint, to echo a little bit what Stephanie was saying earlier, I think one of the reasons we were able to get things done so fast is because of the focus. And do we as an organization think, wow, instead of doing 30 things over the next year, we're going to do 5. And we're going to do them fast, we're going to do them well, and we're going to get them done, and we're going to go to the next 5. And I don't know if that's the right answer or not, but that, you see that with this COVID response, everyone's focused. I mean, the amount of time that it would normally take to get a compliance and legal, and they're great folks in my organization, don't get me wrong, but to go through all those processes, that's frustrating to a clinician that doesn't understand what all those steps are for and think you should be able to do it much quicker. And so the expectations in the bar have also been set a little bit higher post-COVID for business as usual. Hey, wait a minute, we got this done during the pandemic. Why does this take 6 months now? And they're probably pretty good questions. And then work from home, I think, golly, I think we have about 25,000 employees, and we've had around 4 that have gone home for the first time to work from home. So what does that look like from an infrastructure standpoint? What are the costs associated with that? We were always struggling kind of with buildings, and so it adds to the potential solutions in that realm as well.
Ben, anything else you want to add on that?
No, I mean, I agree with everything Brett and Stephanie said. I really like Brett's comments about how we now ask ourselves, well, why did that rollout take 12 months before? We just did it in 3 weeks. And so, same with our company. We worked with our health systems to stand up a brand new telehealth platform that can be used inside the hospital. We built it in 2 months, and we rolled it out in a number of sites in a few days. And those types of projects would have taken months or even up to a year before this pandemic. So
Ben, is it not only so I would imagine on the customer side, they were able to execute a lot more quickly, but also internally, have you been able to see what you're capable of at a quicker pace? So both sides.
Yeah, we certainly have. We had a certain number of capabilities on the roadmap, and this really forced us to bring forward those capabilities, but also do it in a way that was very rapid as a software product organization. Very agile methodologies, having virtual teams working together in voice and chat rooms, building new products and breaking down those barriers. It's been quite profound. And Brett's point about when we talk about burnout, this has also been an opportunity to come together as a team more closely. We were talking before the webinar that we know all of our colleagues a lot better now because we can see what's on their bookshelves behind them, and what they wear to work when they're not having to put a suit on every day. So I think that kind of environment has fostered a lot of creativity and a lot of innovation, at least in our company. And I've seen the same thing in our healthcare systems.
Very good. All right. Let's get a little bit more into the physician burnout angle. So Stephanie, let me start with you. How would you describe the impact of the pandemic on your physicians in the burnout issue?
We've been very blessed, in our region to, not be in a hot spot and certainly not be in a position where we're having to struggle with resources as much or struggle with supplies. So, for us, obviously it's been stressful with the unknown and trying to plan. I think, the biggest area where we really had to focus, where there was uncertainty and just making sure that folks were comfortable was in the space of virtual care. As we moved to seeing all of our patients, or the majority of our patients using those tools and technologies, it was not as widely used here. We weren't really seeing the use of that at scale. So trying to support everyone, adopting that all at the same time, at volume, certainly, create some stress. I think, we were able to work through a lot of that by very much having a focused effort, a very strong interdisciplinary team, very high touch. We actually been on a call every day with one of our providers, just getting anecdotal feedback on what's going on. What are you hearing on the ground? And for me, and I'm relatively new to SCL Health. I've not even hit my full year here. So I'm still in the process of getting to know our medical staff and building trust. It's been a great opportunity to come in there, understand, make sure there are resources available and turn those things around and, deliver on those needs pretty quickly. But, certainly I do think the impact to providers is very much, there's regional differences. There's environmental factors, what's the culture in your organization? How is the administration prepared and what's the support level? What are the volumes you're seeing? I definitely don't think there's a one size, fits all. And I think, looking at our experience, the commitment of the organization, the communication levels, we've done, really, really well. Very proud of how we've responded.
Very good. Brett?
I would only add that we've seen varying impacts based on specialty as well. Primary care all of a sudden went from sort of normal activity to nothing unless they wanted to do video visits, or very few. Then you've got the critical care guys around our system that sort of rallied around each other in their service line, and how can we help each other? And, they're right there in the front line. Same thing with the ED, and what solutions do they need versus, say, a diabetic educator, which is different. And then also in our system, I mentioned we have about 1,400 employed providers, but then we probably have as many or twice as many affiliated providers that work at our facilities. And so their needs are different. Now, we don't necessarily support them in their offices, but we support them in the hospital and trying to help them out, while our video solution in the ambulatory setting isn't theirs because they don't have our EHR, just trying to help them vet products that are out there when they had questions has been part of the impact that we've seen at the system as well.
Ben, regarding what you're seeing with the customers?
Yeah, staffing and resource concerns, having to do more with less is a general theme that we're helping with. Also seeing some interesting use cases. So since elective surgeries have been pretty much canceled across the country, you've got physicians that are now joining telehealth networks or on-demand telehealth that would normally not be doing so, to sort of, and Brett alluded to some of that, is the repurposing of some of the physicians. And so we're seeing that with our tools and the way that they're being used, especially around quick ad hoc telehealth consults and things of that nature.
Well, Ben, there's a tremendous scheduling angle to this, as I'm sure Stephanie and Brett would agree.
Right.
You've got, as we discussed, you've got healthcare workers who are no longer needed as much as they were with elective surgeries being canceled where they were working. Based on their credentials and expertise, they are being, with or without their will, moved around like chess pieces in the health system to where they're needed. Sometimes they're put on nights, sometimes they're put on days, sometimes they're put all over the place. This is a scheduling nightmare. This is being done week to week. This is not, there's no schedules for the month. So talk about that.
Yeah. I agree. You called it a scheduling nightmare. We see this as a huge opportunity where we're helping. So it's one of the two major things we're doing is allowing that surge in demand, the patient load, along with making sure providers aren't, for example, put on back-to-back 12-hour shifts, spacing those out, but also bringing in on the fly providers from that, for example, might have been furloughed in an adjacent health system, so that they can actually get on and onto the rotation, not just for ED and ICU, but also telehealth. So that's essentially the core of what our core scheduling platform does, is allows that really quick, responsive, on-the-fly changes, and more importantly, the optimization to the schedule, so that given that we have this many providers, what's the maximum impact of care that we can provide while minimizing the burden on those providers, allowing them to get their downtime and their sleep.
Yeah, let's talk about that a little bit. Let's talk about this is something I had not thought about much before, but the angle of scheduling, and I guess having a nimble tool like PerfectServe's tool, or a tool of that nature, can be quite helpful. I mean, scheduling could be a big part of burnout, right? So I don't know, your thoughts there.
My thoughts?
Stephanie. No,
oh,
I'm sorry, Stephanie.
Okay.
My thoughts?
Sorry.
Yeah.
No, I mean, it absolutely is a big concern, and I think it's got, more dimensions than just the schedule. It's looking at staffing as a whole, acuities on units, trying to, predict and understand, what that's going to look like, and not just, do we have a body in the seat? Do we have the right body in the seat? Mm-hmm. And are we setting our clinicians up to be successful? This has been just to talk on as a nurse, just to talk on the nursing front a little bit, this has been a huge focus for us, and we've certainly, been doing some things on the fly to make sure that we're giving additional resources to, our chief nurses to understand acuity and really, an additional data point to feel confident about, how we're scheduling and how we're staffing, our acute units. So, it's a constant challenge. And then I think, on the ambulatory side, you've got, the additional considerations. I know for us, we've, continued to push on open scheduling and, putting more in the hands of the consumer, which, obviously creates an additional layer of complexity as we look at, who do we have? And again, do we have the right providers, on the other end of that? And are we doing that in a way that, empowers that consumer, empowers that patient to feel like, they are really, able to make choices independently, and do we have providers that are set up to be successful to respond to that? How our customers, how our patients experience us in these moments will last well beyond COVID. So, that has to be on point. And, I can say we constantly look at, what are ways we can do that more effectively? How do we scale those practices? How do we set both sides of the equation up to be successful?
Brett, scheduling is interesting, and you have a lot of nuances. So right now you've got, people that are credentialed to do certain things that haven't done them in 10, 20, 30 years that are being told to do them. So there's a learning curve there. There's a element of discomfort, but it's almost a war situation. You've got the certification. I can put you here. You got to go here. You'll figure it out when you get there. But I don't know, how is that in the context of burnout and stress and all that?
Well, I would also add the complexity of, I can't take myself as a family physician in our system and put myself in an urgent care and not need some training. I don't mean the clinical part. I've got to learn a different module in our EHR. So we've had to set up kind of emergency video training so they could be accessed at any point in time if our training team's asleep or whatever, to do that. So it's not just scheduling them, it's making sure they can use the tools that are necessary to do that job. I was thinking almost post-COVID too. Right now in a lot of our ambulatory clinics, Stephanie mentioned open scheduling. I think what she meant, and correct me if I'm wrong, Stephanie, but is the patient's got the ability to pick a provider, even if they're not part of the system, and get in. And there's chronically been a tension between, we know that's what patients want, and that lack of control that gives a provider. And I think that's another source of stress. I don't know if you want to say it leads to burnout, but it's a source of stress to say, they won't know what appointment to pick, or they won't. Now, I think there's studies out there to disagree with that, but it is one of those things to overcome that leads to additional provider stresses. I'm giving away control of my schedule to the patients, and what are they going to fill it up with? I think primary care, we have less of a problem with that because it doesn't matter what the schedule says. It could be something totally different than what they said they were coming in for by the time you get done. But I think that's a tension that as providers, we're going to have to get past, because that's out of the patients. If you can't order your pizza on your phone and a time to pick up or a time that's delivered, they want to be able to do their medical care, at least they're scheduling that way. One question I would have for Ben, or just a thought, is, right now, the majority of our ambulatory video visits, that's like 80% of what we're doing. As that starts shifting back to more in-person patients, what's the optimal schedule structure for video and seeing in person? Because it's one thing to sit here and see 10 patients in a row by video. It's another to go, I've got to go to 2 rooms, I've got to do a quick procedure, then I come back to my office and do a couple video visits. What's the optimal, maybe by specialty, maybe by individual? But that's another thing that if we're not careful, we can add to that scheduling stress. Because listen, until we're into a full value-based world, we're not. We are almost all fee for service. We're on a treadmill, and that's how we get paid. Now, it's nice to see some of the barriers coming down for the video visits and the like, but it's still a productivity-based world, and we have to be careful about how we schedule.
Yeah, no, absolutely. I agree. And that's where using a really flexible rules-based scheduling that can take these different parameters and work modes into a single combined schedule. And we're seeing a lot of demand for that. With a given ambulatory site, you've got to balance the visits with the virtual visits in the same schedule, Brett.
Yeah.
One other thing we talked about a lot is the scheduling capacity. But just imagine the communications that go on between providers and to patients and families behind the scenes when you have these schedules that are flexing and changing to surge. And so that's the other thing that we've been focused on, is routing that message or that phone call based on the right provider at the right time. And so it's not, for us at least, it's not just about the schedules and optimizing them. It's about driving the right communications based on those schedules. And that's where we've seen a huge surge in the usage of our primary platforms.
All right, Brett, so now you're on the hook here. You started the Ask a Co-Panelist feature out of turn, which is fine. We're nimble here. So now you have to ask Stephanie a question.
Sure. Through all this, it's really made me think, what's the next thing? I think video and some of these digital technologies, maybe that's the answer, but I'm just curious from your perspective, in the next 1 to 2 years, maybe that gets accelerated, maybe that's a bad time frame, but the next 1 to 2 years, what technologies do you see out there that could help with burnout?
I think probably the one that's most exciting to me is really, ambient clinical intelligence. If we get people more comfortable using, tablets, handhelds, video visits, being able to liberate them from the keyboard as a second phase of that work, I think becomes very powerful. I'm certainly a proponent of anything that we can do that's going to put our nurses and providers and the rest of our care team closer to the patient. So if we can use that technology to record that voice, to translate things into notes, really pull some of that administrative burden off, it enhances that relationship. And it certainly, supports removing some of the barriers that we have that lead us down that burnout path, all the extras. So the more we can use technology, natural language processing, predictive modeling, to provide a service to those clinicians so they can really focus on caring for that patient, we're going to be, I think we'll really start to turn the corner when we get to that place.
All right, very good.
Them from the computer.
Go ahead.
No, I just liberate them from the computer. I 100% agree. I can't wait to see some of it's that data entry piece that drives my colleagues crazy.
Absolutely.
Whether it's an order or documenting the note, and that's why you see scribes, like crazy. I think the voice recognition, ambient clinical intelligence, those kinds of things put scribes out of business, quite frankly.
I think too, another layer of that with legislation, regulatory bodies, payers. You know, a lot of that burden is of data collection is really from those parties. And, you know, I think the more we can start to question where is the value of that, in cases where there is clinical value, I think that conversation becomes much easier to have. We need to collect this information. This is how it's going to be used, you know, to enhance our care process. If we can't really provide a value statement, and certainly, you know, on the billing side of things, you know, we've got some antiquated systems and processes out there that, you know, we really need to focus on modernizing. You know, if we can also get a little bit of a lift in those areas to really question, you know, the relaxation of some rules and expectations in this COVID process, I'm going to be curious. At the end of the day, did we really lose anything? You know, are these questions that we should be asking in the long run? You know, and what's that going to mean? That may help with, I think, some of that data collection, you know, data entry, clerical feelings that our providers have that are, you know, so key in creating the you know, the burnout situation that we have.
Yeah, I would agree. Pushing back on some of those regulatory things, just knowing as a provider, when I come back with an answer like, why do I have to do this? And you say, because I said so, that doesn't sit well. That's
not a good answer.
It's a little bit better to come back and say, well, CMS requires this. If I agree as an organization that that's a silly thing, that it does not provide any value, what I would love to see as an individual provider or collective is to see the organization then push back to CMS and say, where's the value in this? Can we standardize this reporting? I mean, I don't know about you, but how many different requests for COVID data have you gotten from state, federal, local payers? Can we standardize this? Do we really have to have 120 different reports? I mean, that's probably a time for another conversation, but yeah, if you could just see that you're not helpless in this as the end user, as the clinician, to say, wow, somebody is advocating for me and realizes this is not providing value, I think that is tremendous for just morale.
Ben, anything you want to jump in on there?
No, you know, just going back to things will never go back to the way they were, and the applications of technology in profound ways. I was talking to a healthcare system that's now using video visits to triage ED patients when they show up at the ED. That would not have been a conversation before the pandemic, which is a patient showing up at the ED and being sent to the parking lot to an isolation tent where they have an ED triaging session with a physician. So looking forward to all of the continued innovation and access to healthcare that has been spurred here by this pandemic.
All right, very good. We're going to launch our poll here. So I encourage everyone, including our panelists, to take this. First question, dealing with COVID-19 will push physicians closer to burnout. Agree or disagree? Dealing with COVID-19 will not exacerbate burnout, as physicians now have a greater sense of mission. And physician burnout reduction efforts must be put on hold while health systems address COVID-19. So if you want to answer those questions, and then we'll take a look at them in a minute. Ben, I want to give you an opportunity to ask your co-panelists a question. So whoever you want to start with first.
Yes, you know, we talked a lot of, about telehealth today and video. I guess a question for both Stephanie and Brett: Are there other changes to the patient engagement models or technologies that you've seen as a result of COVID-19?
Brett, why don't you go first?
Yes, most definitely. Just the interaction, the desire for patients now that are scared to come to an office or to come to the emergency department and want to do things virtually, not just video visits, but medication requests or just questions that they may have. Also, just the communication of patient to an office or patient to a clinician has changed or is changing. Right now at my office, we don't have a waiting room anymore. You come in, you call when you get to the parking lot, you let them know that you're here, and then when we're ready for you, we'll call you back and bring you in, kind of one at a time. I think there's obviously more elegant ways to do that with maybe texting or some other applications, but that's where we are right now. And I don't, that's not going to change back overnight, even if we had a vaccine, in a couple of months, which is optimistic. So I see that piece of communication, and then the scheduling piece, I think, is that we mentioned is still a real big, I don't say barrier, but all this emphasis on the digital part of care is really going to accelerate, in my opinion, going to really accelerate within our organization, the use of those things.
You gave me this vision, Brett.
Well.
Oh, go ahead, Ben.
Sorry. I was just going to say, I agree. The other areas that I think are the new frontier, and it's certainly things that we're in the process of doing or have done, is also looking at what kind of digital tools are out there that really take some pressure off our clinical staff. There are chat bots now for COVID. I'd much rather a patient, if they're seeking information and maybe not ready to make that call or not ready to make that appointment, leverage something where we know what the content is behind it versus going to, Google for clinical direction. As we look at, even beyond COVID, in a population health world where we're really focused on the health of our patients, not just when they're in our buildings, but also when they get home, looking at things, much more longitudinally. How do we use those types of applications, those bidirectional texting? How do we put algorithms behind that? So maybe it doesn't necessarily have to be an individual on the other side doing it. We're leveraging, data and those modalities to help pick out the hot ones, so to speak, the ones that get kicked up where we know we need to have someone contacting that patient because they've gone off a path, or there's something in what they've said that might indicate that there's a complication or an issue in the care of that patient while they're at home. So, for us, I think the more we can look at what types of tools we can deploy that will be supportive to the provider in some of that data gathering and synthesis, and then really tee that up so that they can spend their time really, treating patients, I think will be super helpful.
Ben, you wanted to jump in? Oh, sorry. Go ahead, Brett.
No, along the data piece, that is a really important point. We can bring Fitbit data into the chart, but as a clinician, I don't want it. It doesn't do anything for me. If on the back end we can provide the reason we're presenting it, it looks like based on studies that this, they're moving less, maybe they're depressed, perhaps you want to reach out. Give me something to do with it rather than just this raw data. We're getting, as interoperability improves, which is great, we're also getting inundated with duplicates and all kinds of things that we have to get smarter on the backside to help out the clinicians, because that's definitely a direct leader to some burnout for sure.
We are data rich and information poor. Across the board, and we've got to get better there.
All right, very good. Let's. Well, I'm not going to share the poll results yet. I'm going to make you guess. I'm going to make our panelists guess. I love this. Okay, so Stephanie, you're going to guess at the first one. Okay. Dealing with COVID-19 will push physicians closer to burnout. Agree, disagree? What do you think the percentage is on the breakdown there?
I think most people are probably going to agree with that, and I'm going to cheat and be a fence sitter on this one because I think there's so many environmental factors that can contribute. I would probably say that's probably a 70-30 maybe.
Wow, very impressive. 74-26. Very impressive. Well done.
Nice.
Well done.
Nice.
All right, Brett, you're up next with number 2. Dealing with COVID-19 will not exacerbate burnout as physicians now have a greater sense of mission. What do you think that breakdown is?
Yeah, 50-50 because I think it's true to a point, or it may not be true in New York City. It's true for us right now, but if this were to persist, it's going to be, no, it's not. It's going to contribute to burnout.
Well,
so
the result.
Go ahead.
Go ahead. Good. No, you're not done.
It's sort of like an immunoglobulin. It's going to give me help temporarily. It's going to give me, a couple of months of immunity, and then it's going to wear off, and I'm either going to have to get it again or do something different.
Well, that's an analogy I haven't heard today until now. So thank you for that. The breakdown there was only 33% agree. about this having some sort of uplifting effect. 67% disagree. So most folks, based on these two questions, think burnout is definitely going to or getting worse because of COVID. So there you have that. Now, Ben, you're going to go with number 3. Physician burnout reduction efforts must be put on hold while health systems address COVID-19. What do you think the breakdown is there?
Just before I venture my guess, is there a prize to the closest guess here? Because I think Stephanie's, I think.
Set the bar.
Yeah.
I think just the respect of the healthcare IT community and the admiration, you know?
I would venture, and the way I feel about this is absolutely this is the time that we need to be focused on attacking burnout due to the strain on our system in these trying times. So I'm going to disagree with that. I'd say probably 10% would say that efforts must be put on hold for burnout while we address COVID-19. Wow, it's
8%. So you're going to, I think you even beat Stephanie, right? He was even closer than Stephanie. What did you get, Stephanie? 70?
I think 70-30.
70-30. Yeah, Ben, you won. All right, sharing results. All right, you win the admiration and respect of the entire community. I can guarantee that. All right, let's get a little bit more. Stephanie, your turn to ask your co-panelists a question.
You know, one thing I've noticed, and again, I'm fairly new in my organization, so forging relationships with our CMIO and we have a new CNIO, and I can say, you know, historically, how much I've valued those relationships, and you know, in a prior organization, really been able to see the value. You know, when you've got IT, you've got your CMIO, your CNIO really coalesced and working as a true team, you know, because that's where we see the opportunities and really help to make those connections and ensure that we're delivering solutions that are simple and streamlined and efficient and provide high clinical value. Just curious, Brett, you know, as you look to forge those relationships and have, you know, interdependence like that, what are the strategies that you're using, you know, with your CIO, with, you know, maybe IT leaders who may or may not be clinical? How do you promote that working as a team, and what are you finding to be successful both in and out of COVID?
Well, that's a great question. You know, I've been in our department now for 6 years and started off as the medical director for our EHR implementation, sort of system-wide. And the humility that I had to bring to that role, because I came in with no IT background. And so what I learned, I mean, I'm sitting in plenty of meetings where I'm thinking, my goodness, what value do I possibly bring to this room of technical expertise? And there'd be this one fork in the road clinically where we said, we're going to build it and it's going to go to the left. And I'm like, oh my gosh, you're going to kill the nurse if you go to the left. You have to go to the right. And the technical folks are like, okay, fine, we'll build it to the right. And I realized my value in that equation, right? And so I think coming at things with recognizing I'm not the technical person, but bringing that clinical value and then showing the technical side of the technical folks, what they're doing, how it's impacting patient care. We haven't done it fully yet, but I really urged our department to say one day a year as an analyst in, you know, with Epic on our team or the infrastructure team, you got to come and spend some time with somebody who's clinical. So you get that impact of what you're doing. I think sometimes, gosh, working at home is probably even worse, but when you're isolated in a cubicle or you're having these technical meetings and you're never on a ward or you're never in the operating room or in an office, you forget, you know, your purpose. And that's done a lot with the relationships that I've forged over time. And I think going through something like COVID is almost like, you know, Anthony mentioned a war, I'd say residency, you know, boot camp, something in the middle. It's a common, horrible thing that you wouldn't choose to go through. But on the other side of this, the relationships that are forged, you can come back to and lean upon. And I think you're joining your organization at this time or in the last, you know, year is probably going to bring a lot of value to have gone through this with them.
Absolutely.
All right. Very good. Very good. Well, we're almost out of time. Ben, I want to give you an opportunity for sort of a last word here. You we talked about your unified communications a little bit is one of the main things your company does. The scheduling piece was a huge element we discussed today and how important that is. Your final thoughts on this environment, reducing burnout. Obviously, from the poll, we've seen that there's concern out there that this is not perhaps the uplifting moment that will remove burnout, that I thought perhaps, that was my theory, I wrote the question, so I thought perhaps there was that element of mission and maybe burnout would come back down the road, but people don't think so. They think this added stress is just going to up the ante. So your thoughts, your final thoughts there.
Well, I do feel that there's been a huge rally, not just within our team, but between our teams and our customers working together to solve problems. And I guess one thing I would say is that I don't see this as a binary event at all. And, there's a lot of talk about, and you read in the media, next time we'll be prepared. We'll have more ventilators on hand. We'll have more ICU beds. But I think or probably more important is this is a good gut check to prepare for the next pandemic or the resurgence of COVID-19, and a check to have all systems in place, including those that we work on, which is communications and scheduling. So, I think this exposes the opportunity to really focus and find sources of burnout and optimize and attack those more than ever. So anyway, just some of my thoughts.
Excellent. All right. Well, that's about all we had time for today. Regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording of this event is ready to view. If you want to sponsor one of our events, you can go to our website or reach out to Nancy from our team, and you can also go there to register for our upcoming webinars. So with that, I very much want to thank our excellent panel. I think we got it gone for another hour, but people have to go to work. Stephanie McIntyre, Dr. Brett Oliver, and Ben Moore. And I want to thank PerfectServe very much for making this important conversation possible. And I want to thank you for attending. And with that, everybody have a wonderful day. Thank you.